we now have a series of challenging clinical cases which we would like to present. And also, so I would like to invite all the expert panel to come and sit in these chairs, and then we will present the cases to them and also get their input. I think we have a total of 6 cases plus a number of imaging quizzes. After that, I will present the first 2 cases. So this is a 41-year-old lady with a family history of that her father died of a stroke at age 40, but otherwise no known history of end-stage kidney disease or polycystic kidney. She was asymptomatic, had normal blood pressures, not on any medications. Her kidney function was normal, but she was found to have bilateral kidney cysts on ultrasound. So she was referred to you for an assessment of possible polycystic kidney disease. Would you order an MR-based total kidney volume risk assessment, genetic risk assessment, both or neither? So this is for the audience to select their answer first, and then we will make comments and also get the expert input. So obviously, if you can have access to both, I think they do have useful complementary values. But if in the usual clinical setting, I would say probably the total kidney volume risk assessment would be the preferred choice. Any comments from the expert panel for this question so far?
I would like to look at the ultrasound also. I mean, if the ultrasound showed just a few bilateral cysts, I might not jump immediately to an MRI, but if the ultrasound showed enlarged kidneys with lots of cysts, then I'd go to the MRI. Always look at the images.
Yeah, I think that's reasonable, and I think we may have to modify the choices for question next year. But I have follow up on this case. So this kind of goes back to Dr. Torres' last presentation. So this patient had a nephrologist who's fairly sophisticated. They actually was able to do MRI and had an outside radiology report. And this is what the report said when the patient was referred to us. Numerous bilateral kidney cysts consistent with PKD. Total kidney volume 1912 ml, high adjusted total kidney volume 1258 ml per minute. Mayo Clinic class 1D. We actually later had mutation testing and did not show any mutations. The question is, based on this information, would you recommend 1, wait and see because the creatinine is normal? 2, review actual MRI to exclude atypical PKD. 3, tolvaptan if patient agree. 4, do both 2 and 3. So the best answer to that is 4, do both 2 and 3, but definitely 2 is also acceptable. So I think it may be also reasonable to just look at the MRI first. So this is actually the image, and I just want to emphasize what Vincente mentioned, that a nephrologist who have knowledgeable who's knowledgeable about PKD management, looking at this image may provide some useful information than just reading a report that the total kidney volume is elevated. I won't say too much about that. I want to just quiz you first, and then we can make some comment. So after reviewing her MRI, would you recommend, 1, perform DTPA nuclear medicine scan, 2, aggressively treat with tolvaptan if patient agree, 3, tell patient she will be on dialysis within 5 years, 4, both 2 and 3? Okay, so this is an interesting kind of question. So what is interesting in this case is that there's definitely diffuse cystic disease involving the left kidney and most of the lower half of the right kidney. But you can see the upper half of the right kidney is completely spare of the disease. Given the age of the patient, this is highly atypical. This is one of the so-called atypical pattern. And so while there is significant disease involving certain parts of the kidney, there is sparing of the upper half of the right kidney. And it's likely this aspect of the disease that is making the patient who is going to do very well, because providing that she does not develop cystic changes in that part of the kidney, she's not going to go on dialysis despite what happened to the rest of the kidneys. So I think that one possible choice would be to assess which part of the kidney is contributing to most of her kidney function at this point as a guide to whether you want to do an additional step of intervention, such as tolvaptan therapy. I felt that probably number 1 would be my preferred choice, but I would like to open to the expert who can also disagree with me. And
no, I agree with your approach. I think it would be interesting to perform the DTPA nuclear medicine scan. I suspect that the function from the left kidney is a very small percentage. If there was a larger percentage of function from the left kidney, that may be information that could maybe make it a little bit consider the possibility of tolvaptan maybe a little bit more favorably. Whereas if there was very little function on that left kidney, then I think the use of tolvaptan would not be, I would not recommend it in my opinion. I think that also be good to have as a baseline to follow the patient. I think it's important to be sure that this segment of the kidney on the right side remains good. We know that development of new cysts at this age is very rare, so I would not be concerned about development of new cysts, but I would be concerned if there was a lot of expansion of the lower part of the kidney that would put compression of the upper part. So I think to be able to follow the patient with MRI and maybe with a DTPA scanning, that would be good. But I would not treat the patient at this point.
Yeah. So we did do a DTPA renal scan. So before I show you more, so this is just a summary, just to show that this case illustrates the atypical PKD pattern that Dr. Khalili mentioned. But in this case, it's a segmental sparing of the cystic disease in the right upper kidney. And this type of pattern is usually very suggestive of somatic mosaicism, which I'll say a few words. And we felt that tolvaptan may not be helpful given the affected part of the right kidney, and most of the left kidney were filled with cysts with minimal parenchyma left. She had nearly normal GFR. We wonder whether it's contributed by the upper half of the right kidney. And so we decided to do a DTPA kidney scan, which is shown here. The scan, please note that the scan, you're looking at the patient from the back. So the right kidney, whether you have the activity, most of the activity, so this is actually the right kidney. So most of the activity is the kidney function is really here. And so based off that, we felt that her prognosis should be really quite good, and we did not recommend any treatment with tolvaptan at this time.
I have a question for Dr. Khalili. So I've asked my radiologist not to dictate reports that say multiple or numerous kidney cysts, but to actually count at least to some number. And if it is innumerable, to say innumerable. And I don't know what the standard of practice is. I'm sure in your practice you get very precise definition, but in the community, I don't know. You know, part of the KDIGO Controversies Conference was a recommendation for the radiology societies to standardize the reporting on, you know, the number and the size of cysts. And I don't know if Canada is any closer to that than the U.S.
So that's a great question, and unfortunately we're nowhere near having any kind of consensus with regards to the reports. I think that to have radiologists at large to follow the recommendations with regards to counting the number of cysts and the location and whatnot would be quite difficult. One reason is the fact that we see renal cysts all the time. It's very, very common. And then to actually measure them, then to give a number, to give out their number, it's an added burden on pretty much every other patient. So you on your side, you see patients who either have a family history of disease or have some renal trouble. These patients are separated out from the large number of patients with cysts who don't have any issues kind of sent to you. I think within our own institution, York can correct me, but we also get lots of reports that don't have the number of cysts, that don't specify the degree of detail that you want to have as a nephrologist dealing with patients with PKD. And I think within the more specialized institutions, you can give them guidelines as to say, if it's less than 10 cysts, please count. If it's, and then beyond that, you can say 10 to 20, 20 to 50.
Yeah, that's what we do.
Right.
There's a range, is not to count exactly how many.
I think a close collaboration with the radiology colleagues is essential, and many radiologists who are not familiar with this disease need to be educated that multiple bilateral renal cysts really is not very informative. We need to, particularly in a young person, you really need to have some kind of quantitative count up to maybe 20 cysts per kidney. That would actually give a lot of information to the referring nephrologist. And then the term innumerable also is very helpful, whereas multiple sometimes is actually could be quite misleading. And
The issue is up front, the radiologist knowing that this is a patient that is going to be seeing a nephrologist with regards to renal function and whatnot, because as I said, you see so many patients with renal cysts. I'm just looking at my oncology population. I've stopped reporting renal cysts unless I think that something worrisome about them, because so many patients have cysts. So it's a very common developmental thing. If you know upfront it's a patient you're going to be seeing, on the requisitions, it would be good to indicate, please provide the cyst count or something like that.
I want to move on. I just want to mention that this case, we suspect the patient has a phenomenon called somatic mosaicism. So this is, so normally when we think about ADPKD as a genetic disease, the disease is transmitted by one affected parent. And so you can imagine that maybe the sperm or the egg of one of the parents carry the mutation, and then they get fertilized to develop a fertilized egg. The first egg and the cell that eventually will divide up to trillions of cells. But during the early embryonic development, when you have a multiple cell stage, it could be 32 cells or 64 cells. One of these very specialized cells, they are essentially stem cells, acquire a mutation at that stage, not at the stage of fertilization, which is a typical way of transmitting the disease from germline. So in somatic mosaicism, the mutation is acquired during one of the multi-cell stage embryo, and it's only one of these stem cells that get acquired. But it does contribute to making eventually the future kidneys, but other cells also contribute. And so you can imagine that the mutation burden in the body is diluted substantially. And so you end up with this kind of patchy changes. And in this case, asymmetric, unilateral, or segmental pattern in cystic disease. So mosaic cases, we suspect, is actually much more common than recognized, particularly in patients who have no family history, who have this kind of asymmetrical, atypical PKD imaging pattern. And typically when you do the clinical testing by mutation screening, by Sanger sequencing, they are negative because the mutation signal also is very low, and you cannot tell from the background signal. If the cell that is affected also affect the making of the germline cell, and then the disease can be transmitted to the next generation, and the affected offspring will have much more severe disease. So I think this is a phenomenon which will pick up more and more because we have more advanced sequencing capacity of next generation sequencing, but it's a very interesting disease. Most of the mosaic cases that we documented or suspect in our experience, the disease tend to stay with the individual. The transmission risk to the next generation tend to be fairly low. Certainly not 50%, could be 10 to 5%, and you may not see that in the next generation. So I'd like to go on to the second case. It's a 53-year-old man, had a positive history of polycystic kidney disease in the father who had end-stage kidney disease at age 50, and also had other affected relatives. His PKD was diagnosed in 2016 during an investigation of proteinuria of 2.6 grams per day, which subsequently increased to 4.6 grams a year later. He had high blood pressure, coronary artery disease, is a smoker, and also had an asymptomatic 2 millimeter left intracranial aneurysm. His serum creatinine was 87 in 2017 and rose to 126 later on in that year. He's on a couple of blood pressure medication. And he was referred to see us for further assessment, but what was already started on tolvaptan by his referring nephrologist. And so the specific referral asked us to do TKV-based risk assessment and genetic testing. So the information we got after performing these testing showed that his high adjusted total kidney volume is 497 ml per meter. So he fits into the Mayo Clinic risk class 1B based on his age, and he had a PKD2 truncating mutation. So based on this information, would you recommend, 1, continue tolvaptan treatment, 2, review the MRI to confirm the Mayo Clinic risk class. 3, do both 1 and 2. And 4, no treatment indicated. Okay, so this is not a straightforward case, and I don't expect that you will have one uniform answer. But probably the best choice would be to look at the MRI first, just to make sure there's nothing unusual going on. Question about continuing tolvaptan. I think at this stage, probably what you find is that the finding is quite discordant, like based on the total kidney volume and genetic, suggests that this person has mild disease, but the kidney function is progressing at a fairly rapid rate, which is very atypical. Another atypical feature is a proteinuria. You can get a bit of protein, but the proteinuria increasing to the nephrotic range is highly unusual. So on that basis, it does not seem that treating him with tolvaptan would be a good choice at this time, but rather maybe further investigation to understand this discordance between the risk assessment and the declining in kidney function require further investigation. So that was our thinking at this time. So this is the image. So you can see that, again, nephrologists should look at this, and this is one of the patterns that Dr. Kalili showed earlier. It's very consistent with fairly mild disease, given his age. So it confirms that the Mayo Clinic classification, it's a typical pattern, mild disease, but why is he having such a rapid decline in kidney function and the proteinuria? So after reviewing his MRI, would you recommend, 1, continue tolvaptan because of decreased GFR, 2, aggressive sclerotherapy, which we really haven't had a chance to talk about, but this afternoon we will discuss more, and then 3, 1 and 2, and 4, discontinue tolvaptan and perform a kidney biopsy. So it's good that most of you chose 4 because I think that what it does suggest is sometimes this case illustrated having the genetic and the kidney volume sometimes provide very important information when you have discordance of what you perceive clinically is happening to the patient. Clinically, the nephrologist is very concerned this patient is doing poorly because of rapid decline in kidney function. But then based on your PKD analysis, both the genetic and the TKV suggest otherwise. And then taking into account of the proteinuria in a very high range, you really have to ask yourself, maybe there's a second disease on top of the PKD. PKD is kind of guilt by association, being blamed for the declining the kidney function. I don't know if the panel want to comment on this. Okay, so he did have a kidney biopsy, and so the finding is compatible with the focal, global, and segmental scarring associated with glomerular hypertrophy, diffuse mild hypoperfusion changes with severe arteriosclerosis. That's the pathological findings, and with the specific changes shown there. It's a very relatively non-specific diagnosis, but it could be indicative of some kind of ischemic changes, and given his history of hypertension, whether he could have some kind of renal vascular disease, but secondary focal segmental glomerular or something else. Yeah. So the case summary this is shown here. So we thought that this patient has a mild form of ADPKD due to PKD2 mutation and discordant renal disease severity, likely related to a concomitant secondary FSGS of unknown cause. And we felt that tolvaptan is unlikely going to help him at this stage, but maybe working on the ACE inhibitor, ARB, to try to decrease the proteinuria, optimizing his cholesterol, blood pressure control, and so those are our recommendation to the nephrologist.
Do you have evidence of poor compliance or higher blood pressure levels in this patient that might have led to the vascular injury?
I'm sorry, I couldn't catch
Was there evidence of poor compliance or
non-compliance?
Sustained elevation of blood pressure?
I don't know because he was a referred case to us. So there's a lot of information we don't have. And we basically saw him once, and the practicing nephrologist has much more information that are not accessible to us. So I think that but he does have coronary artery disease, he does have high blood pressure, but we have no idea about the control of blood pressure. Yeah.
How did you do the kidney biopsy?
Biopsy?
Yeah.
Actually, we find that biopsying polycystic kidney is not so first thing, we talk to our radiologist, the interventional radiologist. We would say, do you think you can do a biopsy? And after reviewing it, and as you can see, like the pattern is fairly mild. The radiologist said, no problem. So we get a biopsy. We have done a few, actually, and even with a bit more severe cystic changes, I have to say our interventional colleagues are amazing, and they really can do a lot. And so I don't think just because someone had polycystic kidney disease, I mean, obviously we worry about bleeding, but in our experience, this has, I think they have to look at the image before the biopsy, and they have to tell us that whether they can access the kidney and they think that they could do it safely. And if they said yes, and generally that doesn't seem to be a problem in our experience.
What's the race of the patient? The race of the patient?
Race. Caucasian. Yeah.
I wonder if there'd be any value of further genetic screening, either Peter Harris's next generation sequencing panel or whole exome sequencing or something, looking for a collagen defect or evidence of a primary glomerular genetic issue.
I agree. I think it's definitely worthwhile. And this is just to illustrate that PKD sometimes is not so straightforward. This kind of discordant pattern, I would say, is not rare. I mean, we see in quite a number of patients. And I think that sometimes as nephrologists, I think we have to think about what the patient's problem. Does it make sense with your clinical information? And I think the discordance between the kidney function and the radiological pattern is kind of a clue that maybe you should look broadly. Another, I think, probably relatively, plausible cause would be thin basement membrane disease, which is very common. And we have seen cases like that had a secondary cause and with thin basement membrane superimposed on PKD, causing more advanced kidney disease that you would expect, and comparing to the imaging pattern discordance. And so I think that especially nowadays, many big centers are using a gene panel that look at multiple genes that could potentially have like deleterious variants that can modify the PKD background. I think in the future, I think we will have like more powerful tools that we could get back to the practicing nephrologists. And, yeah.
Another discordance that was interesting is the two relatives that had very different age of end-stage kidney disease. I think one was still with function at age 68 and one had reached end-stage at age 50, if I remember correctly, so which may indicate that there is another factor that plays a role in the variability of the phenotype in the family in terms of.
Yes, thank you. So my task is finished, and I think Andre is going to present the next two cases. And then Crystal is also going to present two cases related to tolvaptan management after.
So this is case number 3. It's a 26-year-old female nursing student. And we know that she had a positive family history of PKD. That is, her father and paternal uncle both developed ESRD fairly early on, so by the age of 50. She was asymptomatic at that point in time, but she was known to be a poor water drinker. No medications. Her serum creatinine was around 58 micromoles per liter, and EGFR was 102 liters per minute. On a 24-hour urine collection, she had actually a fairly poor volume overall of only 600 milliliters. So she was referred to us for assessment and management. So we performed an MRI. We saw that TKV was around 1,000 milliliters, and height-adjusted TKV was 680 milliliters per meter. And she fit into the Mayo Clinic risk category 1D, so a higher risk for risk progression. And in fact, genetic testing revealed that she had a protein truncating mutation PKD1. So knowing all of this, would you recommend at this stage, 1, to start tolvaptan, 2, to review the MRI and see if she has large kidney cysts, which might be amenable for targeted ablation by sclerotherapy, 3, do both 1 and 2, or 4, do you think that no treatment is indicated? All right, so the majority is kind of split between two possible answers, so either 2 or 3. We think that 3 might be perhaps more indicated. She does seem to be a high-risk patient, so starting her on tolvaptan would seem an appropriate management option. At the same time, we haven't seen the MRI images, so we don't actually know if there are large cysts that could be potentially decompressed. So we decided to do both 1 and 2. And we'll proceed to show you the images. So I will comment on them afterwards. I just want to know your once again, management approach. Knowing what this looks like, would you, once again, start tolvaptan 1, perform aggressive sclerotherapy 2, once again, do both 1 and 2, or 4, none of the above? All right, so most people would both start tolvaptan and perform aggressive sclerotherapy. So we think that essentially there are 2 different ways we could go about this. We think starting tolvaptan would indeed be the right treatment, but we would also be interested in decompressing that one very large cyst we see in the lower pole of the right kidney. It seems to be fairly accessible, and there is evidence that large kidney cysts, especially those that are more centrally located, might actually impact on the rate of declining kidney function. And we'll actually have a talk later on to show you some of our data on that. So that would be our management approach overall. Any comments from the panel?
Yeah, I think that would be correct or be all right. I think if it was my patient, probably I would try to see how the kidneys look after the foam sclerotherapy or even laparoscopic fenestration. I think certainly we could try the foam sclerotherapy first and see how effective it is. But it looks, looking at the if you want to take the big cyst out, the rest of the parenchyma doesn't look really that bad. And I think doing just the aggressive sclerotherapy first and following the patient carefully and maybe starting tolvaptan later, depending on how she does, will also be reasonable, in my opinion. That would be my choice.
Yeah, I think also that, much of the total kidney volume is taken up by that large cyst, so that might not be an accurate assessment of her Mayo classification. And then maybe, subtracting that cyst once you do the sclerotherapy might be, as Dr. Torres said.
I think this is an interesting case in a sense that this young lady has a lot of high-risk characteristic, family history, PKD, protein truncating mutation. So certainly the total kidney volume is large, but this big cyst also contributes significantly. And in my mind, what is unclear is if we can successfully ablate the cyst, change the class, most likely, what does it mean? Does it actually change her natural history? We don't know. So does it actually improve her renal prognosis? We don't know. I think, so I would say just to emphasize, the sclerotherapy is an experimental approach of unproven value at this time. I think more research needs to be done. I think she would be a really good candidate to look at the renal blood flow before and after. We may learn something more. If we could show significant improvement, we probably could think maybe this would be of some help to her. But if there's no change, then I'm not sure whether lowering the volume of the kidney could have changed the natural history. I mean, that's the biggest unknown, is like we now have a way that we could reduce kidney volume. Yeah. So we could change the Mayo Clinic class, but then which is the more valid predictor, before or after? I mean, I'm not quite sure if I have understand.
Well, I think she would qualify as an atypical case, so I would not consider her a typical case where we want to apply the recommendations that we had. But it's a very difficult situation, but I'm kind of, if I don't look at the big cyst and I look at just the normal looking parenchyma, it doesn't look, at least from here, that looks very cystic. It's a very relatively a small number of cysts. And I think it would not be in any way detrimental to her to wait a little bit and watch her longitudinally and see what happens and then decide.
I mean, I sense the audience had a reluctance of considering tolvaptan in this case. I also have some reluctance for two reasons. One is I don't know what this big cyst contribute, particularly if we can get rid of it. The other is she's really a very poor water drinker. We have to try to convince her to drink more water, and we saw her 3 times. Each time the urine volume, despite all the encouragement, is less than 1 liter. So if we start her on tolvaptan and suddenly it go up to 6 liter, she will be very discouraged and very unlikely to be able to continue the treatment. So typically in our clinic, we see sometimes this kind of patient who really drink very little water, and that but they're at high risk and would be appropriate for tolvaptan treatment. Generally, I don't actually recommend tolvaptan treatment at that stage. I ask them to really work hard on drinking enough water. If I can see that they can improve the urine volume to about 2 liter, maybe that would not be a big shock when they go up to 6 liter. But if you always remain less than 1, I have a lot of reservation about it would be just too much for them. And generally, I would be concerned whether she would be a successful treatment candidate for tolvaptan.
So to summarize the case, this is a high-risk patient based on her family history, TKV and mutation-based risk assessment, which would potentially warrant aggressive therapeutic interventions, of course, also taking into account some of the nuances that we just discussed. So we think she'd be a good candidate for sclerotherapy, and as for tolvaptan, it is indicated, but may be difficult to implement because of that poor water intake. So moving on to case number 4, this is a 42-year-old female with, once again, a positive family history of PKD and several affected relatives. Now, she has severe polycystic liver disease, PLD, with significant mass effect symptoms, in her case, bloating, early satiety, and pain. Serum creatinine is normal, and eGFR is preserved at 108 mils per minute. So we have an ultrasound, first of all, and it shows normal-sized but cystic kidneys bilaterally with, however, severe PLD. Once more, this patient is also referred for assessment and management. And on an MRI, we find out that a TKV is 840 milliliters. So based on the Mayo Clinic risk classification, she would be 1B, but her liver volume is actually very high. It's 5.4 liters, which would make her a severe PLD case. As you can see, the normal range is between 0.9 and 1 liter. And on genetic testing, she's shown to have a protein truncating mutation in PKD2. So given all this information, what will be your first-line consideration? You have multiple options. So 1, somatostatin analog, or octreotide, 2, sclerotherapy, 3, hepatic artery embolization, 4, partial liver resection, 5, liver transplant, or 6, no treatment. All right, so most people would either go for somatostatin therapy or sclerotherapy. In our case, we would suggest somatostatin because based on all the clinical information we have, it appears to us that it would be the most appropriate first-line therapy. Sclerotherapy could be considered based on what the liver actually looks like. And if we do, in fact, take a look at her images, this is what we see. So once again, I will comment on this afterwards, but would you change your approach? Would you still recommend starting with the somatostatin analog? 1, 2, sclerotherapy to ablate so those large cysts you can see, 3, hepatic artery embolization, 4, partial liver resection, or 5, a liver transplant. So this time, most people agree that sclerotherapy might be perhaps more interesting as first-line therapy. We do, in fact, see at least 2 very large cysts in the right lobe of the liver, including 1 massive cyst that takes up almost the entirety of the right lobe. So perhaps decompressing these large cysts might change the patient's symptoms. Any comments from the panel regarding what the exact order of the interventions ought to be like?
Difficult to comment because I don't see the images well enough. If what I see there on the upper right lobe is the whole thing is a big cyst, and then you have another big cyst below that, then I think trying the foam sclerotherapy would be good. My concern is that it's a very big cyst, if that's a cyst, and some of these very big cysts are difficult to treat with foam sclerotherapy. So another possibility would be just doing laparoscopic fenestration of this cyst and the other cyst at the same time. And that may be, but there is nothing wrong with trying foam sclerotherapy first and see what happens. So that would be reasonable too. But I would like to see more of the MRI in order to be more confident.
I think, I don't know if Dr. Slomovich is here. Aaron, are you here? Do you want to come up here? So Dr. Slomovich is one of our interventional radiologists who really has a lot of experience, and particularly this would be not just a large cyst, this is a giant cyst, you know. So technically it's very challenging to ablate it with foam sclerotherapy. Maybe you can make some comment on your experience, Aaron?
Sure, yeah. So we've done a bunch of liver cysts that are, probably bigger than a liter like this. The success rate doesn't seem to be as good as in the kidneys, and it'll take multiple sessions, probably 2 or 3 sessions over a couple of weeks to get this ablated, but you can still get a pretty good response. I'm not a liver surgeon, but we have seen a few patients that have had previous fenestrations, and then the cyst has recurred, and then they've come back for sclerotherapy afterwards. So that's not always a perfect technique either, but I agree. I mean, I think foam sclerotherapy is a reasonable first-line option here, and you can usually get pretty good results, but it may take several sessions.
I think the comment about the recurrence after the fenestration is a very, very good comment, but the issue relates to the expertise of the surgeon. I think a common error both in the kidneys and the liver, but I think I have seen it more on the kidneys, that sometimes the surgeons go there and they do tiny fenestrations that very dangerous because they recur, they kind of seal off and recur. So you have really to do very wide fenestration, then there is no recurrence.
I can comment on a couple of cases that I have personal experience. It's a kind of giant cyst in severe polycystic liver disease. And one case was not successful despite multiple attempts. And I don't know what is a technical factor. The other was successful after a 2-stage procedure, like with a drain left in and then injection after. And but what is interesting is after the treatment, the patient has a lot of pain for a period of time.
That with the sclerotherapy.
After sclerotherapy, yeah. And I was kind of wondering, like, because you basically have a big hole and the liver is kind of, and a few months later, the liver shape changed. So it kind of remodeled itself, like that hole is gone, like largely gone, and you have a small kind of a residual cavity. So, and I don't know whether when you ablate this kind of large cyst, sometimes you can have associate pain that is related, whether it could be something because you're stretching this capsule of the liver, maybe triggering some stimulation of the pain fiber, or I'm not quite sure. But the pain was more sustained than related to the procedure for a long time. We have to actually give the patient pain medicine, and then for maybe about a month, and then it completely start to get better. And then 3 months, like it was completely gone. And so I was just wondering, but when look at the 3 months liver, is very different. Like that big hole, like that was from the cyst is like largely filled. Like so, the liver tissue seems to remodel itself, and whether that itself sometimes can trigger like some kind of pain.
I think in terms of fenestrating large liver cysts, we have had seen quite a bit of experience on that because Dave Nagorny has been a very experienced surgeon doing that. And I think there are a number of things that are very important. One, you have to take as much of the wall as possible, and a very, very wide fenestration. Second is to do some kind of burning. They have another term. They use an instrument to kind of actually burn all the lining of the remaining cysts, because otherwise you can have a lot of fluid secretion for some time, which can be a problem. So I think there are some technical surgical aspects that are really very important and that determine how successful these procedures are. And I'm not a surgeon either, so certainly I don't want to, but I know from what I have been told that that's the case. And
I want to mention that before we did the sclerotherapy program, we had another patient, I don't know, Aaron, if you remember, and we have another radiologist who was working with us who had since retired. So we have a giant cyst in she was in her 40s with intractable pain, like on opiates and unable to work, so severely debilitating. So we were wondering how to get rid of the big cyst, and after a lot of discussion, So we decided the radiologist decided to insert a microwave probe to heat up the fluid to kill those cells. So the idea was good, but the first time it didn't work, and then he said, well, the temperature didn't go high enough. So next time, he drained the cyst, filled in saline that was heated up at a certain temperature, put in a microwave probe to heat up the solution, and it did go up high, and then we heard a pop, and the cyst burst. And it was completely effective, right? And the patient had pain for about a month, and then afterward, she was back to normal, off all the pain medication. And again, the liver changed shape. Yeah. And then afterwards, after several months, it looked completely different. That big cyst is completely gone. So this remodeling aspect, it seems to be fairly dynamic when you get rid of big cysts. But in our experience, the patient continue to have pain for a period of time before they get better. And I don't know whether in some way it's triggering some kind of pain-sensitive fiber when the liver change shape. Yeah.
Actually, sometimes we have seen also with a very, very large cyst that sometimes you have a reposition of other organs, and maybe the colon goes up to fill up or to where the space of the cyst was before. And we have had cases like that, yeah.
Yes, so just to make a couple comments on the pain, I mean, we definitely see more pain on sclerotherapy of liver cysts than kidney, because one thing, it's kind of an intraperitoneal organ, so if you get a little bit of leakage of the sclerosant, you just get some irritation in the area, so that's a bit more common. So when we sclerose liver cyst, we actually try and go through a bit of normal liver or an adjacent cyst to try and limit that risk of foam leaking into the abdomen. And we've seen a decrease in the months of pain when we've done that, as opposed to the kidney, which is retroperitoneal. We go directly in because the foam can't leak too far away. The other thing is that we definitely see pain as we drain the cyst in these large liver cysts. Everything kind of shrinks at once. The patient gets uncomfortable, and I think that's when the kind of the 2-stage, 3-stage procedure is really nice, because it lets everything kind of drain slowly, and everything can remodel with time, and then the surface area is a bit smaller the second time you inject it, so you get better contact with the foam. So you do need several stages for these giant ones.
So a summary of this case, severe PLD with several very large to giant cysts. Successful ablation of these large cysts by sclerotherapy may provide an effective means for liver volume reduction, and then somatostatin might have a role later. So just a bit of a variant here. If this was in fact the patient's MRI, what would you do? And the options are the same. So most of you would choose somatostatin therapy in this case, and we agree.
How old is the patient?
This is the same patient actually, so she's in her early 40s.
No, it's a different scenario.
It's a different scenario. It's like
what if?
Yeah,
you know, like,
yeah,
what if?
yeah. But it's supposed to be the same patient.
Okay. No.
So in this case, we have severe PLD due to innumerable small to medium-sized cysts, and it would be reasonable to start a patient on somatostatin. So other treatment options would include partial liver resection, which can be possible in an experienced center, but it is invasive, of course, with potentially serious complications. And then liver transplant is very much a last resort treatment to be used rarely.
Yeah, the only point I was going to make is that after menopause, sometimes big polycystic livers can get smaller without doing anything. So if this lady was going through menopause or postmenopausal, there's nothing wrong with going on somatostatin, especially if the patient is symptomatic. But if the patient is not very symptomatic, maybe the first thing to do is to do another scan 1 year later and see whether actually the liver is getting smaller. Because if it's getting smaller, there's no point in treating her with anything.
Okay, so these next two cases are looking at patients that are being treated with tolvaptan. So this first person is a 36-year-old new mother with a 9-month-old child. When she came to us for an assessment, she was found to be high risk, so class E. So she was started on tolvaptan. At the time she was starting, she had a fair amount of renal impairment as well. 3 weeks into her treatment, we follow up with her and she complains of extreme fatigue. She's very thirsty at night. She's drinking 3 to 4 liters at night alone and is waking up 5 times to use the washroom. When I ask her what time she takes her doses, she says at 10 a.m. and 10 p.m. Based on this information, what would you suggest? Would you tell her to change the times that she takes the medication? Would you decrease the dose of her tolvaptan? Would you suggest eating a smaller meal at dinner time? Or would you add hydrochlorothiazide 12.5 milligrams to her medications? Okay, so the majority suggested that she change the times that she takes the medications. So we also did the same thing. She moved up her evening dose to 6 p.m., but still takes the first dose at 10 a.m. 3 months later, she's now waking up more frequently to use the washroom, so 6 or 7 times a night. She's still fatigued. When we did a 24-hour urine collection, her volume was 5.8 liters and her osmolality was 110. Based on this information, what would you suggest next? Would you decrease her dose at this point? Would you add hydrochlorothiazide? Would you suggest eating a smaller and low-salt meal at dinner time? Would you do both 1 and 3, or would you just reassure her that it will improve? Okay, so the majority suggested that we do both 1 and 3, so decrease the dose and eat a smaller meal at dinner time. We did both of those, but in different steps. So first we tried decreasing her dose, the morning dose to 30 milligrams, but still kept the afternoon dose at 15. Keep in mind that tolvaptan for us doesn't come in 30 milligrams, so she had to cut a portion of her pill in the morning. She did that for a few weeks and there was no improvement, so she eventually changed her dose to just the 45 milligram dose in the morning and then tried eating a smaller meal at dinner time. When we follow up with her after a few weeks, she says that her thirst at night is better and she's waking up about half the time now. When we did the 24-hour urine collection, her volume was pretty similar. Osmolality was 122, and then we had her do a first morning void collection and her osmolality was 139, which was well within the target we were looking at. She's feeling much better now. I was just wondering if there was any comments from the panel in regards to this case.
And the one comment is also this patient may drink more water than she needs to, because urine osmolality in the morning has been very low consistently, so maybe one of these patients that is over-compliant with drinking water, so maybe another thing that could be done.
The first dose at 10 a.m. seems quite late in the day. I encourage all my patients to take their first dose as early as possible in the day. Now that may affect a commute or childcare or things like that, so it may not be possible, but 6 a.m. then gives you your second dose at 2 p.m., which is further away from bedtime. Maybe I get in trouble for saying this, but in the United States, GnRQ can be provided in 15 milligram capsules. So I don't know if GnRQ can be provided as such, but that would give you, I'm not sure she needs to have a UOSM of 110, as a trough.
Ron, I think in US you have wider choices of dosage. And in Canada, I think we have blister packs, and I think 30, 15 is the lowest dosage. But in US, you have more way to modify your dosage.
It initially started out as only the blister packs,
Uh-huh.
although I understand that some of the clinicians got the pharmacy to unpack the blister packs and provide lower doses. But now in the US, 30 and 15 milligram formulations are available. Not advertised, but they are available. But again, I don't know about Ginarc, because we're dealing with a different, we prescribe Ginarc Q.
Okay.
Okay. So moving on to the next case. This patient is a 42-year-old male. Once again, on his assessment, he was found to be high risk, so class 1E. He was subsequently started on tolvaptan, 45/15, but he switched his doses because he would sleep during the day and work during the night. So 5 weeks into his treatment, we follow up with him. He tells me that he's drinking 3 to 4 liters a day, but he doesn't feel thirsty. He's deliberately drinking this amount. When we do his 24-hour urine collection, his volume is 2.45 liters. His osmolality was 255, so lower than baseline, but not as low as we'd like to see. Based on this information, what would you do next? Would you increase his dose? Would you stop treatment? Would you continue to monitor? Would you check his compliance with taking his medication? Or would you do both 1 and 4? Okay, so the majority of you said you would do both 1 and 4, so increase the dose and check his compliance. So that's exactly what we did. So he did confirm that, we did confirm that he was taking his medication as instructed. And then we increased his dose to the next step, which was 60/30. So 4 months into treatment now, he's still drinking 3 liters deliberately, still doesn't feel any thirst. His urine volume is slightly lower, 2.25, and the osmolality hasn't really changed. So based on this information, what would you do next? Increase the dose, stop treatment, ask him to increase his fluid intake or water intake consciously, or both do 1 and 3. Okay, so majority says do both 1 and 3, increase the dose and increase his water intake. And that's exactly what we did. So he's now up to the highest dose, 90 and 30. We're now just over a year into treatment. He's drinking 5 to 6 liters of water a day, but he does feel a little bit of a thirst with this highest dose. But we have encouraged him to increase his fluid intake so he's able to meet the 5 to 6 liters. And when we did his urine osmolality for the 24-hour urine, it was 193, so below the 200 that we were looking for. So I was just wondering if the panel had any comments in regards to this gentleman. Yeah. Okay.
So he seems to have some problem with sensing thirst in this individual, and I don't know if you have any experience, a patient with thirst disturbance.
No, I don't. I was going to ask about what were the plasma sodiums in this patient at the different stages that you showed, to see whether the plasma sodiums were consistently high, or the other way around. That might give some indication of what's going on, whether he is not sensing the thirst, or whether he may have some constitutively active vasopressin V2 receptors that dictates a higher amount of drug to block. I don't know. It's kind of
So his serum sodiums were typically between 140 and 143, so he's never hypernatremic at all.
that would indicate that probably is not sensing thirst then.
Okay.
Okay. Okay, so we now have an imaging quiz, and Dr. Khalili is going to talk to you about.
I know that I'm standing between you and lunch, so I can assure you these are relatively quick. So we're going to start with case number 1. So these are 3 different patients, each one of them in a column, patient A, B, and C. All 3 of these patients are young, between 20 and 25 in age. They all have positive family history for autosomal dominant polycystic kidney disease, and they all have normal kidney function. So what's your diagnosis? Patient A and C have mild disease. Patient B likely has PKD1 protein truncating mutation, the severe format. Patients A and C are sisters, or both 1 and 2 are correct. You can start voting now. Excellent. The people who voted for option 2, patient B likely has a PKD, and everybody else who voted for option 4, both are all correct. This patient, in fact, did have PKD1 protein truncating mutation. You can see that the kidneys, there's very little parenchyma. The kidneys are affected diffusely. But patients A and C also do have mild disease. There are a few little cysts on both sides. Keep in mind that these are patients in their 20s, so it's abnormal to have cysts in their kidneys, and this number at that age. So we're going to go to quiz number 2. All the 3 of these patients are between ages of 40 and 45, and they all also have a positive family history of renal cystic disease. So here the question is, patients A and B have mild disease. Number 2, patient C has severe disease. Number 3, patients A and C have PKD2 mutation. Or number 4, both 1 and 2 are correct. Great. So the correct answer is number 4. Patients 1 and 2, you can see, given their age, there are very few cysts in the kidneys, but there are cysts in the kidneys as well. So this would qualify as mild disease. And then, of course, patient C has very significant disease with very little parenchyma, if any, visible. The kidneys appear completely replaced with cysts, and they're quite enlarged. So the answer 4 is correct. And we're going to the final imaging quiz. All 3 of these patients do not have family history of autosomal dominant polycystic kidney disease. So what's your diagnosis? Patient A and C have moderate disease. Patient B has the most severe disease between the 3 of them. Patient B most likely has PKD1 protein truncating mutation. And number 4, all are correct. Okay, wonderful. This is the right way to go for lunch. Just to make a point that, yes, patient B did in fact have protein truncating mutation, and patient C, in fact, if you can see, there's asymmetry of disease with areas in the left kidney that are hardly involved. And in fact, on testing, I had somatic mosaicism with 11% of the white cells in the peripheral blood being positive for PKD1 mutation. And with that, we're going to end the quiz session.
I just like to make the comment that as nephrologists, if you can look at the image, just emphasizing Dr. Torres' point, then you will begin to develop a good sense about the severity of the disease, because you have the information about kidney function, family history, and all that. And most of the time will be pretty good, I think, and not to rely on a reported TKV or like. So thank you very much. So this concludes this morning session. We now have lunch, and then the session will resume at 1 o'clock. Thank you.